Hi, my name is Lady Sanchez. I'm the pharmacy intern on staff today. So we have Margaret Thompson. She's a 27-year-old African-American female that comes to the clinic complaining of increased asthma symptoms, although she doesn't have any signs of acute distress at the moment. She states that she has had daytime symptoms approximately 3 times per week and uses a rescue inhaler 3 to 4 times per week, but not multiple times during the day. She's also had problems awakening during the night and approximately 1 time per week, and her symptoms are not tied to exertion alone. She states good compliance to asthma medications and demonstrate proper inhaler technique. So our problem today is to figure out if we should change her asthma medications. Her past medical history includes mild persistent asthma for over a year, generalized motor seizures for over 2 months, although this is well controlled with topiramate. Her family history is not really pertinent to this case. She is a former smoker. She quit 3 years ago, and she doesn't use alcohol. She has allergy to gabapentin, from which she gets edema, and her medications include topiramate 100 milligrams by mouth twice daily, Trisprintec 28-day pack 1 tablet daily, fluticasone propionate or Flovent 44 micrograms per actuation, 2 puffs by mouth twice daily, albuterol or Ventolin 90 micrograms per actuation, 2 puffs by mouth every 4 hours as needed for shortness of air. She's up to date on all of her vaccinations, and she had her influenza vaccine in January of 2020. Her respiratory examination showed increased asthma symptoms, mild wheezing, and no acute distress presently. Her psychiatric evaluation showed intermittent insomnia. Her vitals are blood pressure of 110 over 72 millimeters of mercury, heart rate is 90 beats per minute, temperature is 36.8 degrees Celsius, respiratory rate is 18 breaths per minute. She's 69 inches tall and weighs 158 pounds, and her BMI is 23.3 meters square, which is normal weight. Her labs show a serum creatinine of 0.8 milligrams per deciliter, and her creatinine clearance based on this is 120 millimeters per minute. Her CO2 is 24 MEQs per liter. So this patient is presenting with a problem of uncontrolled asthma. Based on her asthma symptoms, we can determine that they are uncontrolled, and she doesn't have any risk factors like use a beta blocker, NSAIDs. She doesn't smoke. She is not obese, has GERD or depression or anything like that. Patient is currently on step 2 of therapy. She's taken a total of 176 micrograms per day of Flovent, which is a low dose ICS, and she's also taken Ventolin as needed. Since her asthma is uncontrolled at the moment, we should move on to step 3 of therapy, which includes adding a long-acting beta agonist. I would recommend using a combination inhaler that has budesonide and formoterol. The brand name for this is Symbicort. This is tier 1 on her insurance formulary, so it will be relatively cheap for her to get. As far as dosing, I would start with the lowest dose just to minimize the side effects, and then we can work our way out based on how she responds to this. We can reevaluate after 1 to 2 months of starting therapy, and if she's well controlled after 3 months, we can decide if we can step down on therapy. This patient should continue to use Ventolin as her rescue inhaler, since it's very important for exacerbations. My goals for this problem will be to control her asthma symptoms and to prevent future exacerbations. The drug regimen would be Symbicort, 80 micrograms of budesonide, and 4.5 micrograms of formoterol, 2 puffs by mouth, once or twice daily and indefinitely, or as long as we decide to keep her on this therapy. As far as safety monitoring, we want to watch out for oropharyngeal candidiasis or oral thrush and tachycardia. We can see if this medication is working, but if we see that it's relieving her symptoms of shortness of air. Alright, so that is all that I have. If you have any questions, please let me know. Thank you.